Now I'd like to ask you to welcome Claire Sparke. Claire is with the Australian Institute of Health and Welfare, and today she's going to speak about patient experiences of coordination and continuity of care. Now, the little fun fact about Claire is that she is a true Canberran, which means that on most weekends she heads to Maruya. And I'm sure we will all agree that that is certainly a mark of true Canberran. But the other thing you might know, and I'm really excited to think, she plays the trumpet. So.
Thank you, and thanks for sticking around for the afternoon session, everybody. So I'm here to talk to you about a study that we've commissioned, and we're doing, called the Coordination of Healthcare Study. And I'm just going to give you a bit of information about the Institute first. For those of you that don't know, I'm sure quite a few of you do. But we're an independent national data agency in the health portfolio. We were established in 1987, and we're supported by enabling legislation to use specific data use and confidentiality provisions, which gives us access to a wide range of data. We've grown a lot over the years. Started off with 68 staff, and we've now got more than 400. Started from 13 reports a year to 180. So we provide regular statistics in all the domains that you can see there. In 2016, we absorbed the health performance and accountability functions from the National Health Performance Agency, which is where this study originated. So those are our strategic directions: leaders in health and welfare data, drivers of data improvement, expert source evaluated analysis, and champions for open and accessible data, and trusted strategic partners. And this study really fits into particularly those first three. So I probably don't need to go through this slide given the audience. But why is coordination of healthcare important? Well, many Australians, as we know, experience fragmented care caused by disorganised or discontinuous flow of information, communication and communication and coordination between providers. And we think that understanding patient experiences and their perceptions of coordination is important for improvement. So as I already said, the study was commissioned under the National Health Performance Agency, which later transferred to the AHW. The National Health Performance Agency independently reported on a large number of indicators under the Performance and Accountability Framework that was agreed under the National Health Reform Agreement in 2011. Under that framework, there was a continuity indicator, which was to be developed. So the National Health Performance Agency went and consulted with a number of experts, and there was feedback that they wanted to see more indicators on the reporting across the sectors between primary care and acute care. The ABS regularly run a patient experience survey, but it's only designed to report at the national and state and territory levels. And there's a general policy direction in most developed countries to look more at patient-centred care. This has flowed on to the new Australian Health Performance Framework, which was agreed recently, and there's a whole domain there now on continuity of care. So our study, the Coordination of Healthcare Study, has two parts. The first part is the survey of healthcare, which was run in 2016 by the ABS, asking people about their experiences of healthcare, and I'll go into detail on that a bit later. And the next part is a data linkage component, which will link MBS, PBS, including our PBS data, and hospital data from every state and territory around admissions, but also emergency department data. The study's objective is to fill an important information gap relating to patient experiences with continuity and coordination of care, and to provide contextual and locally relevant information to primary health networks. This study is sampled at the primary health network level, so we can report by primary health network on all the data that we have. And the hope is that primary health networks will be able to use the information so patients can get better experiences with coordination of care, and GPs will be better placed to provide care to patients that's subsidised through the MBS and the PBS, and potentially fewer patients going to the emergency department. We'll be able to analyse indicators of healthcare in local areas on themes around access to care, patient-centred care, and information sharing amongst healthcare providers, and also look at certain population groups of people with chronic conditions and people who've been admitted to hospital. So it's fairly complex once you try and get all those data sources together. So this is the governance structure of the study. It was approved by the Department of Health Research Ethics Committee in August 2015, and the survey of healthcare was run in 2016. We also have had to go back and forth a number of times, as anyone who's done a data linkage study would know, to various committees. The Department of Health, the DRAP Committee, and the Department of Human Services External Request Evaluation Committee. We are going through a process now of talking to all the states and territories, data linkage units, data custodians, getting ethics approval in every individual state and territory. And we have a number of internal sort of governance structures as well. Doing this linkage will allow us to sort of look at participants' responses and their actual health service use 12 to 24 months before they were surveyed, and also 12 to 24 months after they were surveyed. The linkage to the MBS and PBS is somewhat less complex because we use the Medicare database to sample the survey, and we have consent from patients to link using that database. But the hospital linkage is much more complex in that it involves every state and territory and all of those ethics committees that I just talked about, and trying to get a consistent data format across the states and territories can be difficult. We hold the National Hospital Minimum Database at the AHW, so we are negotiating getting the data out of that in a consistent format instead of having to go to every state and territory individually, which is a plus of it being at the AHW. Okay, so we haven't done the data linkage yet, where the ABS are currently just merged the MBS data, and we'll be putting out a report with them towards the end of the year. But we have done some analysis on the survey, so I'm just going to go into the survey of healthcare now. So it was a paper-based mail-out survey, voluntary self-report of patients who are 45 years or over and had at least one GP visit in the year before they were sampled. We oversampled what we termed high users, so people with 12 or more visits, which was about half of the sample, and in comparison, in the general population, about 25% of the people have 12 or more visits a year. It was stratified by age group, sex, PHN, socioeconomic status, and, as I said, number of GPs, and it's been weighted by the ABS to be representative of the population. So the survey asks a number of things. It asks about the way people used healthcare, waiting times for GPs, after-hour services, those lots of things about GPs, length of relationship with the GPs, whether they had a usual GP or usual place of care. It asks about use of specialists, whether they were seen, could get in, waiting times, etc., and information transfer back to GPs. Medications, whether medications had been reviewed and what went wrong if they didn't. Tests and x-rays and scans, whether somebody had been referred, could they go, did they have to wait. Emergency department attendance, hospital admissions, emotional and psychological health, and long-term health conditions, amongst other things. So that's the demographics of the sample by remoteness areas. There was about half were from outside of major cities. And so we had 29% from inter-regional areas, 15% from outer regional areas, and 4% from remote and very remote areas. most people assess their health as good or very good or excellent. The age distribution was similar for all the regions, and major cities had the highest non-English speaking respondents, as we would expect, and also the highest rate of a bachelor degree. The most common educational attainment was year 11 or below, which is not surprising given the age group is 45 or over. So we released some data, which is on our website, so I'll give you a snapshot here, but if you want to see more, you can go to our website and have a look at it. This is about information sharing between, this is whether people had usual GPs or a usual place of care. And as you can see, the usual GP, I've gone too far, sorry, I need to get back. Well, there we go. The usual GP, people having a usual GP decreased with remoteness, as did having a usual place of care. We've looked at, as I said, information sharing between general practitioners and other services. And here's, again, as you can see, as remoteness increased, people reported that their usual GP or usual place of care didn't seem informed of what had happened in the ED, the hospital, or at a specialist more than in major cities. Just looking a bit closer at the emergency department, you can see, as I said, that information sharing decreased with remoteness. But there's an interesting finding there as well that people in remote and very remote areas reported not having any follow-up needs more than people in other areas, so 14% compared to 6%, between 6 and 7% in other areas, so we're not quite sure what's going on there. When we link this to hospital data, we'll be able to see why they went to the emergency department around the time that the survey was done, so that we might be able to get some insights into that then. We asked about barriers to accessing GPs, and about 25% of the cohort in all areas reported that they didn't see a GP when they needed to. As you can see, as you would expect, by remoteness, the reasons for not seeing a GP when needed were due to no GP nearby increased, and the cost decreased, which is across all these barrier questions, which we're not quite sure why. Grateful if anyone had any insights into that. It's perhaps more pronounced in the next one, the cost as a reason why a barrier to seeing a specialist. No specialist nearby was very high in remote and very remote areas, as was unable to get an appointment across the board. And cost was a major barrier in cities. Barriers to access for tests, x-rays and scans was again quite high, no facility nearby in very remote areas, and cost increased this time as we went into regional areas, but dropped off for remote and very remote. I must note all of these, they could tick more than one, so they could have ticked all three if they wanted to. Seeing a health professional for psychological and emotional health. Again, cost was a big barrier in major cities and dropped off with remoteness and no service, but something that came up here was embarrassment, and it was similar across areas. And for physical health, service availability in rural and remote and very remote areas again, but cost was the most common one for other areas. We asked patients about whether they had visited an emergency department in that time, and visiting the emergency department increased with remoteness. and we really want to know why they went to the emergency department. When we asked them why, this is what they said. The first two, you would hope that you would go to an emergency department if you had a life-threatening condition or you were told to. But again, waiting times and GP not available were quite high, as in very remote areas. So this is a large program of work for us. We are going to be putting out PHN level results in July on GP experiences, and that will be on the My Healthy Communities website, which has a lot of local level information at PHN or lower SA3, SA4 if we're able to do that for all the work that we put out there. And later in the year, hopefully towards the end of the year, we'll be putting out another report on experiences with information transfer in detail, and then a further report next year on access to healthcare, which by then we'll have linked data for, along with the report with the ABS later in the year, looking at the survey across MBS usage measures. Thank you.